Muchas gracias. Those are the only words, unfortunately, I can say in Spanish. I would like to thank you for the kind invitation to share with you different aspects on the understanding gambling and how to deliver treatment for pathological or disorder gambling. There are two terms that we will clarify as we go along. Usually my English is quite easy to understand because my first language is French. I'm a French Canadian. Sometimes they call us the frog in Canada. And of course, my second language is English. I usually speak quite slowly and I make short sentences. So I don't think it will be a problem for you to follow the different issues that we will talk about today. Let me just make sure. Okay. What we will cover over the next maybe an hour and a quarter, and I will have time for questions, is I'll review with you very briefly the basic issues of the psychology of gambling and trying to understand why do people gamble. Then we'll make a formal diagnosis. We'll talk about the official and the non-official diagnosis of disorder gambling. Then we'll emphasize the treatment of disorder gamblers, focusing on the concept of dissonance, on cognitive therapy for the problem gamblers. And I will allude the goal of treatment. This is a controversial issue, but you will see we have empirical data showing that should we go only for abstinence as a goal, or we can work with the patients to achieve controlled gambling. And we'll have time for a conclusion and some discussion. Before I start, I would like to, what we usually call the declaration of interest. I am a member of the International Group on Responsible Gambling, along with my colleagues Blazinski from Sydney, Australia, Peter Caldens in South Africa, David Fong in Hong Kong, and Howard Schaefer at Harvard in Boston. And I'm also a member of the Independent Assessment Panel of the World Lottery Association with Anne Patberg from Denmark and Henry Shang in Hong Kong. Well, that being said, why do people gamble? Well, I'm sure that all of you do have an answer. They do. You have an answer of why do people gamble? And if we would be on a face-to-face basis, we could have a long discussion explaining why I think people do some gambling. Well, we'll move away from opinions and we'll talk about some empirical work that has been conducted to illustrate and to answer why people gamble. And why this is so important, as you will see, with those basic notions, this is what we will use in the treatment of problem gamblers. Well, my very, very first question is, what is gambling? Well, you work in this field, and I'm sure that this notion, you feel that you understand it quite well. You probably do. But at the same time, let me sort out the main issue and the main definition of what is gambling. First thing is that people must realize that they're putting money or valuable object at risk. Second one, and the operators, the lottery or the casino operators, know that very well. Once this money is bet, it is irreversible. And finally, and this is one of the focus of my talk today, the outcome of the game is determined by chance. Well, on this slide, I'd like to make two comments. The first characteristics that is on the slide, number one, it involves money. So when we talk about gambling, we're not talking about gaming, playing video games. Video games do not imply money. So we should make a distinction between gambling and gaming. And the other one is the outcome is determined by chance. Well, all I will say tonight applies to all games except one, which is poker. I'll talk a little bit more about the importance of chance or not in poker. So what is chance? It's you use this term many, many times in your work, in your daily life, but we very seldom define what is chance. Well, chance, if you're a statistician, you talk about probability, but chance is an unpredictable event. It's from an operational standpoint, and that is very important in gambling. This is the impossibility of predicting the outcome of an event. Well, we need to clarify two opposite concepts, chance and skills. And immediately with your patients, you will probably find very useful to identify the level of chance that your patient perceive in all the games and the level of skill. We'll clarify that in a minute. If I would ask you, what is the main characteristics of skills as opposite to chance? Well, skill, the more you play, the better is your performance. The more feedback you receive, the better is your performance. And practice increase your performance. As opposite, if you would play bingo or keno 5 hours a day, 5 days a week for 5 years, you'll never be a champion in bingo. You will never be the gold medal, or winning a gold medal by playing keno or bingo. So this is the main distinction, that regardless of the time you spend gambling, you will never become an expert. So why do people gamble? Well, the necessary condition, and the operators know that quite well, it's the possibility of winning money. If there's no possibility of winning money, there will be no gambling at all. And as a clinician, and you who are listening to me tonight, majority are clinicians, put a lot of attention on what your patient is telling you. In many cases, in my clinical practice, I've seen patients trying to put away the gambling problem and trying to get my clinical expertise to focus on the other problems they have, marital problems, social problems, problems of their job. Well, it may be the case, and it is usually the case. We call it simply comorbidity. And as a kind of an anecdote, I ask the students or my trainees in clinical when we do clinical workshop, I say, where do we find pure pathological gamblers without other problems? Some people say, well, maybe in Quebec, Canada. I said, no. Maybe in Córdoba. I said, no. Maybe in Buenos Aires. I said, no, 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 no. So finally they said, where do we find them? And my answer is simple. We find them in textbooks of psychiatry and psychology. When a person consults, as you know, there is comorbidity. So be very careful of not focusing and accepting. Many patients will try to convince us as clinicians that they do have a gambling problem because they have marital problem. They have both, and they're not necessarily causal. That's very important. So that being said, why so many people continue to gamble and some become addicted to gambling? Well, the main reason is that most of us, all gamblers, misperceive or deny that the outcome of gambling is based on chance or randomness. And many studies, and I'll show you in a second some details of those studies, when you take all the study together, analyzing what people say to themselves, what are their internal monologues about gambling while they gamble, there's a very robust result that we obtain. About 80%, 80% of what people say to themselves when they gamble are erroneous perception, inadequate perception. And most importantly, and you'll see the detail of that, those erroneous perception are a common denominator is that they're making links between independent events. And I'll show you, I'll detail that in a second. Those who listen to me now, think of your patients or think about one of your friends or if yourself, when you gamble, think about one erroneous perception. Well, one erroneous perception that often comes when people play the machines like video poker or when they play blackjack and they lose for a certain amount of time, they say the machine is due. The machine now is about ready to pay. The blackjack, I should have a 21 now. I've lost so many times in the past. Well, all those events are independent, but I'll show you why we think this way. And the operators, again, are quite aware of that. The more the individual is active, the more he perceives that he can predict the outcome. If I'm in competition, best example, playing blackjack. Maybe you have this this advertisement here, but go to Vegas, and what we hear very often is we hear, beat the dealer. Well, you cannot beat the dealer. The frequency of gambling increased the erroneous perception, and many more. Let me give you a few examples. In lotteries, people who pick their numbers, let's say at the 649, value their ticket much more than those who pick their numbers randomly. One study we conducted in Canada a few years ago, we asked people who pick their numbers on a lottery ticket and people who let the machine pick their number. we ask the people who pick their numbers, would you exchange your ticket for one that I have in my hand where the numbers were randomly picked by the machine? If the person says no, we offer 2 tickets. If they say no, we offer 3, 4 tickets. In the other group, where the machine picked the tickets, when we ask them, would you accept or change for 1 ticket? Well, 1 for 1, they did not accept. But in the other, if we pursue and say, well, we'll give you 2 tickets, would you accept? Well, the conclusion is that in the group that they pick their numbers, they asked for much more tickets. And some said, even when we were at 10, you will never get my ticket. I keep it for me. So another good example is go to the casino and look at people playing the roulette. Well, people analyze prior numbers and colors before placing their bets. At a crap table in Las Vegas, this game is based on throwing a dice. Well, if you want an I number, like a 6, people would throw their dice hardly. But if you want a 1, you'll just throw it gently on the table. So what is the difference? None. Well, the main common denominators among all the erroneous perception is making links between independent events. And I hope you can see. I will ask my colleague here, we'll make a little experiment. In this glass, I have 10 marbles. 9 are white and 1 is black. So what is the chance? Let's say that the black one, you win the blackjack. What is the probability that you will win the blackjack in this case? There's 10 marbles, 1 out of 10. Okay? So you pick a marble and it's a white. Put it there. So now what is the probability? 1 out of 9. I pick a white. Now, what is the probability? 1 out of 8, right? And if I continue gambling, I come to the case that there's 1 black and 1 white. The probability is 1 out of 2 that I'm going to win. Well, that's the way the gambler think and perceive the game. But how does the game work? Put the 10 marbles back. I pick a white. And I put it back for the second time, second game. What is the probability? 1 out of 10. I continue to play. I have a white. My probability is 1 out of 10 because the marbles are always back in the glass. So in the first case, this is how the gambler perceived the game. In the second way is how the game works. So this is what making links between independent event is probably the most crucial thing that happened. Then you'll see how we apply that in the treatment of problem gamblers. Should I ask for a question at this time? No. Okay. No. Perfect. In addition to the erroneous perception that you will work on in the treatment, be aware of the following result. In a study, and that was replicated, in a study we did, we asked people when they playing the machines, and their erroneous perception would be the machine is due. what is your degree of conviction that the machine is due? Here, what we did. We had people with the DSM-4 criteria of pathological gambling, age about 40 years old, and we had regular gamblers, but not meeting the DSM-4 criteria. They played the game while they were thinking out loud. That means while we asked them to say out loud what they were saying to themselves. And the sequence was pre-programmed for all gamblers. We asked two major questions. The first thing is how convinced that the machine is due from 1 to 10. And the second one, we rated their perception as adequate, erroneous, or neutral. Well, the main result shows that the erroneous perception were a bit higher in the pathological group. But the main importance, and you'll see how we use this information in the treatment, they were much more convinced as they go along than the non-pathological gamblers. And look at this curve. The red are the non-pathological gamblers. The more they played and they found out that the machine did not pay, they were less convinced that the machine was about to pay. But the pathological gamblers, the more they played and the machine did not pay, they became more convinced that the machine was about to pay. So as you can see at the very beginning, they were about equal. They perceive, oh, yeah, the machine will pay. But as we go along, we find a major difference that the pathological gambler believed that the machine was about to pay. And that's one of the reasons that they continue gambling more than they should. Okay. We want to have time to talk more about treatment. Let's talk now about the diagnosis of pathological gambling or disorder gambling. Well, if I take the non-official, what do I mean by non-official? I mean, what are the main characteristics of a pathological gambler? Main characteristics, as we know, is that there's a loss of control. They lie about their involvement in gambling. We find family, job, social disruption. Many will steal money. I'll say a word a little later on that. I had the opportunity to be an expert witness in court, in legal cases, where some problem gamblers steal money. They were arrested, and I went to court to testify for them. And the main aspect of my job was to explain to the judge that those gamblers, they're not criminals, they're not psychopaths. They steal money in order to continue gambling and the hope of recouping their losses. They're getting the money that they've lost. What is the prevalence of disorder gambling? Before I get to the official diagnosis, I'd like to share with you that the prevalence, as probably many of you know, around the world today, when we look at the prevalence studies, we find that in the general adult population, the prevalence studies varies from 0.5 to 2%. This is roughly what you will find if you conduct a study in Argentina, in Córdoba, in Buenos Aires, or in other countries. This is generally what we find. Well, you may know that now in the DSM-5, there are 9 criteria to make a formal diagnosis. And if you meet 4 of them, you'll be classified as a pathological gambler. And one precision or detail that we should put on the table, we hear many terms, and I purposely use quite a few so far. Problem gambler, pathological gambler, excessive gambler. What is the right term? Well, if you go by the official, if you work in an hospital, if you go to court to testify, you need the official. That is, for us, at least in North America, we use the DSM. Well, the DSM-5 changed the name. They don't talk about pathological gambling, they talk about disorder gambling. But generally speaking, many people talk about problem gamblers, excessive gamblers. So far, from now on, we will talk about disorder gambling. 4 or more criteria and the other precision in the DSM-5, now we have a time window. Before the DSM-5, we would have, were you ever preoccupied with your gambling activities? Now, we will say within the last year, have you been preoccupied by your gambling? And that's a major important. Let me go briefly over those 9 criteria. The first one is need to gamble with an increased amount of money in order to have the excitement. Second one, people get restless or irritable when trying to stop. Usually the gambler made repeated unsuccessful efforts to control, cut back, or stop gambling. Very often preoccupied with gambling. They always think about getting money in order to go back. Often gamblers feel distress. And probably the most important criteria is number 6, what we call chasing losses. After gambling, the gamblers return another day, another night, to chase his losses, trying to win money that they've lost. They lie about the extent that they gamble. They would jeopardize some relation, job, educational, social one, and they rely on others to provide money to finance their gambling activities. If the person meets 4 out of 5, they're called mild. If they meet 6 or 7, they are moderate disorder gambler. And if they meet 8 or 9, they are severe disorder gambler. From probably your clinical experience, at least in my clinical experience, mild gamblers do not knock at your door. Moderate gamblers will not knock at you. They will not ask for help. They will ask for help when they get to 8 or 9, when they're severe. Well, as you can see, if we merge the official and non-official, there's a practical and a kind of an empirical way to see this disorder. Generally speaking, I tend to believe that the worst question us as clinicians should ask the patient is, how much money have you lost gambling? It's natural. Usually we ask that. Well, the answer, especially if you see a couple, and here I don't want to be sexist, but quite a few are males and less are female. But now, at least where I live, more and more female will become or are disorder gambler. So if the disorder gambler sits in your office and is accompanied by the spouse, the person will say, I gambled this amount. And immediately the wife will say, this is not true, you gamble much more. And they will start arguing, playing ping pong, that no, I don't gamble that much. Yes, you gamble more. So, well, why is it probably useless to ask how much money you've lost? For one reason. Some people can be very rich and can afford to lose a lot of money. Others are very poor and cannot afford to lose even 1,000 pesos. They cannot afford. So on a very empirical way, a disorder gambler is a person who plays more money than they can afford to lose. They will play longer periods than their situation can afford. If you're a retired person, you probably have more time for gambling if you can afford it than a full-time employment. And you play more often than you can afford. I never met Bill Gates, but I'm quite sure Bill Gates can afford to lose much more money than all of us in one evening at the casino. And that will not be a problem. So the amount of money is a question or is a characteristics that has its importance, of course, but always translate this amount in what they can afford to lose. Well, probably this is the most important slide that I will present to you today. Robert Custer, the psychiatrist in the US, was the person who lobbied the most to introduce pathological gambling in the DSM. That time, probably remember, in 1980, pathological gambling was introduced in the DSM-3 under impulse control disorder. And it moved to addiction. Well, this slide that I present to you was first described by Robert Custer, and I made an interpretation of that. So Custer described the career, may I say, of a pathological gambler in those three phases. The first one is the majority of the people you'll see in your clinic, when they started gambling, they had a periods of wins. It was exciting. If you continue gambling, you will probably lose. And if you continue, you'll get in a period of despair. Well, in the phase of the losing phase, all the collaterals the spouse, the father, the children will say, stop gambling, you're getting into trouble. And the gambler does not listen. And in this phase, the gambler will not seek treatment. And my question, it's too bad that we're not on a face-to-face conversation, but I'll try to illustrate with my hands what I want to say here. In the losing phase, all the surroundings, all the collateral, they know that the gambler's in trouble and he's in the losing phase. But the gambler does not believe that he or she is in a gambling phase. They interpret this phase as a timeout of the winning phase. And this is quite important because, as you'll see in a few minutes, not too many gamblers seek treatment. All the others, they say, go to treatment, but they don't. And the more you put some pressure on the individual, saying, go to treatment, stop gambling, there's no response because the gambler does not believe he or she is in a losing phase. Simply, they're in the timeout and they should continue gambling. So that is probably one of the biggest problems on how we can structure some information that the gamblers will go to treatment. Hope it makes sense for all of you. Well, that being said, what is the treatment? Well, of course, in the 15, 20 minutes that are left, we're not on a face-to-face basis. I will conduct a workshop here in Córdoba, a 2-day workshop on the treatment. And we'll do practical exercises. We'll do some role playing. But let me give you a kind of an overview of how we can proceed in order to change the gambler's perception. The main method, and you're probably aware of this book that we wrote, it's been used in many, many countries now, been translated in many languages. There's a workbook that's for the patient, and we have a therapist guide that, and what I will be talking in the next minutes are coming from, we wrote in this book. But before we go talk about the treatment itself, let's put our clinician hat. Let's be a clinician for a few minutes. An understatement or an attitude that we too often clinicians forget about what stopping gambling means for the gambler. The person sitting in front of you asking for help, immediately we say, well, that person wants to stop gambling. Well, not necessarily, because there's a lot of the attitude that we should sort out and discuss with the patient before actually we introduce the treatment itself. And I would say doing this is part of the treatment. I think as clinician, we need to recognize that the patient has to accept and recognize that the money lost is lost forever. Remember 2 slides before, I told you the timeout. And the gambler, many people that we see in the clinic, they say, if I can recoup the money I've lost, I will stop gambling. Well, we know that this is probably not the case, but they need to accept that the money lost is lost forever. And probably over the last few years, they've gambled to recoup that money. The second reason on the slide is probably so difficult for them is to declare to yourself that you've been beaten by gambling. Remember I said that earlier? Beat the dealer. You want to win. You want to be the winner. But here, you've been beaten by gambling and you have to accept that. This is not easy. I like to make the analogy when you see a patient with OCD, obsessive compulsive disorder, you don't have to go through this because the OCD, they want to get rid of their compulsive checking or washing behavior. But here the person does not necessarily want to stop gambling because gambling, it's fun. They did win money at times, and now they have to change their attitude. You have to accept that you've lost an important activity. It's fun. If you can gamble within your limits and you like it, it's fun. You have to stop thinking that gambling is the solution to your problem. But this is what I've said a little earlier. They do have comorbidity. And they say, well, if I can stop gambling, maybe that will solve my problem. My other problem, probably not. They have to plan a financial reorganization. They all have debts. So how will they pay back the debts? So they have to work hard in developing new strategy. I took more time maybe that I should going through this slide, but I want you as a clinician to keep in mind that it's not that easy for a gambler to come and seek help. Well, in the book, we talk about different aspects. We talk about social skill training, problem-solving training, relapse prevention, and I'll say a word on the relapse and dropout in a second. But where is the most probably difficult thing is how to modify their erroneous perception. And here I'll make a very strong statement. If you do not modify the erroneous perception of the gambler, soon or later, and I would say sooner than later, you will have relapse. You will have relapse. If the gambler, if the person still believes that sometimes it's my lucky day, and you haven't changed that, there's a high probability that there will be a relapse. And that's not easy to modify. It's not easy to modify because you cannot avoid the first circle, the triggers that I call. The triggers could be reading something about gambling in the newspaper, seeing an advertisement, talking to someone who likes to gamble. That will be triggers. And what are the triggers do? They triggers some interpretation, some perception, what we call the cognitive variable. And if you still believe that those perceptions are true, you will go gambling. If it's my lucky day and I'm sure that I will win, why I should not go. I need to modify this perception. Well, before I get to that, I'd just like to say another aspect. Don't forget, as I said earlier, 80% at least of the perception of the gambler are erroneous. They are irrational. They are inadequate. And mainly those erroneous perceptions are spontaneous. They are implicit. And very often, the gambler is not aware of those erroneous perceptions. And our job is to make them aware and modify those erroneous perceptions. So keep in mind, they are automatic. They come spontaneously. And that makes our clinical work quite difficult because it's spontaneous. Well, I'll tell you how we do it in a second, but the treatment that we develop shows that within about 15 to 20 sessions, patients who do complete the treatment, they have about 80% success. About 80% of the people who complete the treatment, which is usually around 15 to 20 sessions, they will stop or control their gambling, as I will explain in a second. But be aware of the high dropout rate. Roughly, 1 out of 2 who start treatment will not continue. After 1 or 2 sessions or 3 sessions, they will not come back. And very often, they will not even call to cancel their meeting with you. But at the same time, the good news is many dropouts will come back later to treatment or will stop gambling by themselves. But the dropout is very high. How can we prevent? We wrote a few papers on dropout, and in the 2 days I'll be giving a clinical workshop. I'll talk about how we can decrease. But those of you who are here tonight will not be there. Let me just say that one way to handle this is to warn, is to inform the patient that they may have a high tendency after this session not to come back. Some patient, for example, they will tell me, "What? You think I'm not a good patient? You don't like me? You think I'm not motivated?" I said, no. You think I cannot successfully complete? No. I always say that. And they said, "Well, why do you think I may not come back?" I simply say, well, we know that 1 of 2, regardless of their condition, they do not come back. And they say, "Why?" I said, well, maybe tomorrow you'll have a trigger, like I just talked. And what will you do with this trigger? And they say, well, I don't know. They ask me what I will do with this trigger. I say, come back next week and we'll talk about it. What I mean here is that if you inform the patient that there's a high tendency not to come back, you may help that person to continue the treatment. Well, the cognitive correction, that there are many ways. For those of you who work in cognitive therapy, you know that there are many models to change the cognitions. Among them, we need to understand the concept here of randomness. We need to understand what are erroneous beliefs, be aware of inaccurate perception, modify those erroneous perceptions. That looks very nice on in a book or on a slide, but how do you do it? Well, the way we approach is by creating dissonance in our patient. What is dissonance? Well, I'll just briefly allude on how we create dissonance. But before I say that, I will jump to two slides that I want to, next slide that I want to show you. Confrontation with the patient will not work. Giving information is not sufficient. Why? Because patients have spontaneous, implicit, erroneous perception. What we need to do is to increase their awareness about their erroneous perception and let them figure out how to solve that. Creating dissonance for me is like injecting them doubt, challenge. I want my patient to start challenging their attitude toward gambling. And on this slide, I take the example that my erroneous perception is jumping on a machine that has not paid for a certain period of time. So gambler will look, they will look at different machines, and they will say a person leaves a machine because the machine hasn't paid, that's a good machine. I hope you agree with me that this is an erroneous perception. Well, with that erroneous perception, I will approach, but that will take maybe 1, 2, 3 sessions, but I'll make it here in a few minutes just to illustrate where I want to go. I will ask the patient and look on the preferred machine. I will ask the patient, did it ever happen that you played on your preferred machine, which is a machine that hasn't paid for a while, and you did win? Well, the patient will say, what? Yes, of course. When I played on a preferred machine, I usually win. Okay. And here I'm trying to create the dissonance. We'll say, did it ever happen that you played on your non-preferred machine because of all kind of reason, the machine, you didn't know if the machine has paid or not, and you did win? And the patient will say, yes. I will complicate even more. I will say, did it ever happen that you played on your preferred machine and you lost? Again, patient will say yes, because it's random. As a therapist, you don't believe that those games are based on randomness, don't treat disorder gamblers. And did it ever happen that you played on your non-preferred machine and you lost? So you see here, I have four squares. Preferred machine, non-preferred, winning. Preferred, non-preferred, losing. And I will say to the patient, what do you say to yourself when you realize that? And here I'm increasing awareness by putting the patient in a situation that on their preferred machine, Sometimes they win, sometimes they lose. And even on their non-preferred machine, sometimes they win and sometimes they lose. So my belief that playing on the preferred machine is a winning strategy. So they have to start challenging by themselves this strong conviction. You remember the conviction that the machine hasn't paid is increased as I play? Well, here, what we do not provide them information. We do not provide them confrontation. We create a situation where we're increasing their awareness by creating dissonance. And what will happen? Many patients will say, God, I never realized that. I may be stupid. No, 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 no. I'm an idiot. No, 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 no. What? And again, my attitude is, what do you say to yourself when you realize that? I say, well, okay, think about it. We'll talk about it next week. See? I don't want to give the answer. I'm the coach. At soccer game, I'm not the player. Especially, I don't want to talk about soccer in Argentina, coming from Canada, but you as a therapist, you're the coach to get the players making the goals. You're not telling them what to do. Hope it's clear. Cognitive dissonance, as I showed, is not confrontation. It's not teaching. It's facilitating the increase of awareness. Well, I thought that I would end by 9:15. I have about 9 minutes to address the last issue. And that's a controversial issue. Should the treatment be abstinence, or as clinician, can we accept to work on controlled gambling? Well, how many individuals are disorder gamblers? Well, we saw from 0.5 to 2%. How many will seek treatment for their gambling problem, do you think? Small percentage. What is that percentage? Well, many clinicians, we see that less than 10% of those 2% will seek formal treatment over the next 3 years. So it's a small proportion. It would be important to increase that. So, a few years ago, that was probably the most difficult study to conduct, because nobody, the federal government, the national government, many funding agencies did not want to help us to finance this study. And here, I hope I'll be clear. Our preoccupation was why people do not go to treatment. Well, it could be a timeout. We agree. But there may be other reasons. And one of the reasons we had was that many disorder gamblers do not want to go to treatment because they know if they seek professional help from psychologists, psychiatrists, a social worker, nurse, whatever, they know that the goal of the treatment will be to stop gambling. And for them, they want to continue because they want to recoup the money they lost before they stop, so that they don't go to treatment. That was our hypothesis. So in order to do that, here is what we did. We made some advertisement, distributed information in family doctor's office, in many areas where, and listen just to the sentence we use. We said, if you want to control your gambling activities, and I'll get that slide here, call us. The labeling, the wording was very important. We didn't talk about treatment. We said, if you want to have a better control over your gambling activities, call us. Well, it turned out, oh, there's a slide. It turned out that 89%, I'm sorry, 89% did call us. And 89 of them were disordered gambler. They were all problem gamblers. All of them knew that treatment exists, but they did not want to go to treatment because they did not want abstinence. Well, there were a few, more than the 89, there were a few who said, now I want abstinence. And we said, perfect. My colleague will help you. Here we work on controlled gambling. And you'll see the result. The most important result is the most unexpected result. So at no time, if you can see on red, the goals were accepted by both the problem gambler and the therapist. At no times the therapist tried to talk and induce abstinence. So the patient established their own goal. How much money they want to bet each time they gamble, how much money per week they want to spend, how many gambling sessions, and how many hours, time, and minutes they want to gamble per week. The successful outcome were that at the end of treatment, the patient will not meet the DSM-4, at that time with the DSM-4 criteria. So the successful outcome was not if you control or abstinent, but are you a pathological gambler or not? Well, here is the result. So the completion, 69% completed the treatment and 31% drop out. So here is an interesting result because usually the dropout is about 1 out of 2. Well, here the dropout is 30%. If we use what we call the intent to treat, it's a bit of a methodological issues, but I'll explain to you later on that. The outcome of the treatment was 63, 56 at 6-month follow-up, and 51% at 12 months. But here the intent to treat is people who drop out are considered failures. If you take the completers, those who completed the treatment, after the treatment, 92% were not pathological gamblers, according to the DSM-4. At the 6-month follow-up, 80%, and in 1 year, 71%. So when I talked to you a little later, a little earlier, that the success rate is about 80%, those are the results. The last slide is the most interesting, and I said, unexpected result. At post-test, After 15, 20 sessions, 39% decided to go for abstinence. And remember, all those patients did not want to go to treatment because they knew they don't want abstinence. But during treatment, the therapist never suggested abstinence. Therapists work hard to help them to control their gambling. Regardless, 39% shift to abstinence. At 6 months, 40%. And at the 12-month follow-up, 32%. Wow. Here is my question. And here is the most unexpected result, is why 30 to 40% to abstinence. And it's too bad we're not sitting in the same room, but I would ask each of you, how do you explain this result? And I must say that in all the workshop that I gave, practically no one could give the right answer. And I'll be even more personal. Even us as therapists, we did not know until we asked the patient. And you know what the patient said? For many years, I've been gambling, trying to control my gambling. I knew I could find a way, but I didn't find it yet. When I saw the possibility of working with specialists like you, my team, offering me to increase my control over gambling, I said, wow, this is the solution. So we work with you. You accepted the goal. And here is the main reason, even working with a specialist, helping me to control my gambling, I did not succeed. So, if I want to be honest with me, the only solution is abstinence. Working with specialists who helped me, provided me good advices, good strategy, and even with your advices, I could not control, then I have to realize that abstinence is the solution for me. So what is the main conclusion? Well, the main conclusion is that you may want to reword the service you offer to your community. Maybe the word treatment is a bit threatening. Maybe you could word it in a way that, and believe it, those people, they wouldn't go to treatment before for abstinence. So you may word it in a way, well, about control, if you accept that. My time is practically up. As a conclusion, I would say that, well, we all know now that disorder gambling is officially recognized as a psychiatric disorder. We have well-defined diagnostic features. Validated treatment exists. Comorbidity is the rule rather than the exception. And as the last kind of way to introduce the goal of treatment, I would say be aware of the patient goal. Maybe you could help people to come to treatment if we talk more about control than abstinence. And here, I think controlling can be defined. You can control your gambling activity by stopping or by gambling more, not more than you can afford to lose. Well, thank you. This is was the main issues. We still have a few minutes for question, if you have any question.
This is not a question, but it's a comment. It says it's a very interesting lecture about the treatment. It's really interesting to see how many of them chose the non-imposed abstinence. That's a comment from Andrea Romano.
How many did not? Can you repeat?
Yeah, I'll repeat. It's a comment from Andrea Romano. She says it's a really interesting lecture with conference regarding the treatment. It's interesting to see how many of the patients chose the non-imposed abstinence as opposed to the imposed.
Absolutely. You're absolutely right. Is when they had the choice, they, about 30 to 40% decided to go to abstinence. And that was not imposed by an external expert. It was their own decision. And how do I interpret this important result? It's my clinical hunches, but I'll share it with you. The way I interpret it is that while working with them in controlling their gambling according to their own idiosyncratic criteria, they became aware of their gambling attitude, their gambling activities, and this awareness brought them to a point that it's my choice, and the better choice, my best choice, is to stop because I cannot limit myself when I start engaging in this activity. So, right, you're absolutely right. It's a decision that the patient took by him or herself because they were confronted in their daily activity, and then they realize that they cannot control it.
So that there is a limit, and that limit is imposed by the subject.
The limit is decided by the subject, by the patient, and the limit could vary from 1 week to the other. I mean, if you would be my patient, we start this, and I say, well, next week, how much money you are ready to lose or to put at gambling? You may say 10,000 pesos. But over the days or over the weeks, you may say, no, I think that's too much. I prefer 5,000 or more, whatever. So the goal in terms of time and money spent gambling was always determined by the patient. The only time the therapist intervened is when it seemed so inappropriate. The therapist would say, well, are you sure this is what you want? Therapist will never say, that's too much or that's not enough. But the therapist will more reflect, are you sure this is what you want to spend?
We have one last question by Isabel Silvetti. She says, the dissonance alternative was very interesting. Would that mean exposing the subject to the way they perceive the game, that is, exploring with the subject, with the patient, the way they see their gaming activity?
Absolutely. It's also the most privileged way to modify their erroneous perception, because the patient will be doing some gambling and they become aware of what we've taught in the therapy session room. So they can transfer in the real gambling situation what they became aware with you as a clinician. Absolutely. Very good comment.
We have another one by Lucia Bianconi.
Hello.
Could we affirm that the treatment of the pathological gambler is based mainly on the work by cognitive distortions and automatic thoughts?
Good point too. If you look in our book, and I should have said that, and thank you for reminding me, what I usually say in a workshop is the cognitive tool that we're talking about, and listen very carefully to what I will say. I say the cognitive tool that you will learn is a necessary intervention, but in some cases, not sufficient. Very good. And if you, well, I'll just go back. When I talk about the treatment, as you can see on the slide, there's also problem solving, social skill training, relapse prevention. Those are the behavioral aspect and many others. Why I decided to focus on the cognitive correction, like I said, if the patient did not become aware of or is or her erroneous perception, soon or later, a relapse will probably occur. And modifying those erroneous perception, I would say, is probably the most difficult clinical job we have to do. And here, that's why I give the workshop on this, is with, you need to see it sometimes. You need to see how you do it. In a clinical workshop, I usually ask two volunteers. One will play the patient role, the other one will play the therapist role. I'm the coach of the therapist, and if it's getting more difficult, I'll do the therapist. And you see how. But the main point is never argue with the patient. You are the coach, like I said, to bring the dissonance in the patient, that they will realize that their conviction, the way they pick the machine, the gut feeling, my lucky day, are not appropriate, and they're not the solution. They need to challenge that. So yes, it's not, and many other problems. For example, I said there are comorbidity. Well, of course, there are many comorbidity. The main comorbidity is the other addiction. They have another addiction. Should we start? Should we start with the other addiction? Should we start with the marital problem if there are? Again, my approach is I ask the patient which one you want to start with. I do not impose. The more active they are in the treatment, they decide, and I will follow it, unless my clinical expertise make me think that, no, maybe we should not do it. If I believe as a clinician it's not the right way to go, I will tell them, but I will not impose. Hope I answer your question.
Traduciblemente yo le digo, ya no queda tiempo para más preguntas, pero me parece oportuno agradecerle al profesor Ladouceur su enorme exposición. Creo que ha sido brillante, simple, fácil de entender, ha tenido mucha paciencia. Agradecerle a los compañeros del capítulo por la participación, a Cecilia García, nuestra presidenta, por su esfuerzo, no de este día en particular, sino de todo el año, para que podamos debatir y juntarnos. En lo personal, el equipo de Juego Responsable de la Lotería de Córdoba, que se ha hecho cargo de toda la parte técnica, y a nuestro presidente por haber financiado la posibilidad de que el profesor Ladouceur estuviera entre nosotros. Mañana va a haber una segunda intervención en la Facultad de Psicología, van a estar todos invitados, porque se trata de una presentación híbrida, también mixta, presencial y virtual, en la cual se nos ha dicho que va a haber más de 200 personas. Y después la jornada de capacitación propia. Así que muchas gracias a todos. Gracias por preguntar, gracias por participar, gracias Cecilia y gracias a los colegas. ¿Sí?
May I say just one thing is thank you for your nice conclusion, and you can see my email. So if there's any material you would like to have or any question, I'll be happy to answer them if I can. But the only problem is I will have to answer them either in French or English. Thank you.
Okay.
Muchas gracias. Muchas gracias a todos. Gracias, doctor. Que tengan buenas noches.